Hello, anatomy friends. This is Dr. Alsup, and let's begin our discussion of the joints of the lower limb with two of the big ones, and certainly two of the more clinically relevant ones, and that is the hip and the knee. All right, so always return to these learning objectives. Make sure that you can answer these, and let's get started. All right, so we talked about some of the joints associated with the pelvic girdle, with the SI joint and the pubic symphysis. There was not a lot of movement there. It's really there for stability. The hip joint is certainly more stable than what we had with the other ball and socket joint in the shoulder, but it is capable of the same movements because it is a ball and socket joint, and you can see those here. So you have flexion, extension, abduction, and adduction. When you can do these four movements, you can also have circumduction. And then ball and socket joints, remember, are capable of medial and lateral rotation as well. The range of motion is not what you have in the shoulder joint because necessarily this joint needs to be a bit more stable, but there is a good amount of mobility here as well. And again, you can kind of click on this link here in order to view some of these actions and visualize those. As discussed in previous videos, we are going to have the articulation of the head of the femur and the acetabulum of the coxal bone or the hip bone. So this is the very definition of a ball and socket joint. This really looks like a full socket. It's quite a bit deeper than what we had with the glenoid fossa of the scapula. And then we have a more circular head of the femur than even what we had with the head of the humerus. So a very good ball and socket joint here. Again, you have a labrum associated with this ball and socket joint, similar to what we had with the glenohumeral joint. There are lots of ligaments associated with the hip joint, and they're all very well named in terms of where they attach. So from what bone to what bone. I'm only going to have you know one specific one, which is your iliofemoral one. And the reason I'm having you know this one is because sometimes you will see this in the literature referred to as the strongest ligament in the body. It certainly has a lot to do. It has a lot of protection of this anterior portion of the hip joint. The posterior portion of the hip joint is pretty well protected by tendons of some very large muscles that are located more posterior, whereas you don't have quite as much when we're talking about this anterior portion of the hip. So ligaments are of great importance here, and specifically the one that is located here is the iliofemoral. And as its name would suggest, it is extending from the ilium all the way to the femur. And it will play a role in terms of just overall protection of the hip joint and stability, and it'll also help to prevent hyperextension of the hip joint. You can see some of the other ligaments in these images here. Here's your pubofemoral, which is going to be a bit more inferiorly located than the iliofemoral. And if you look at a posterior view, you can see the iliofemoral again. Again, this is a very large ligament here. And then you can see an ischiofemoral ligament. But really, in terms of the one that I want you to make sure you understand its location and kind of what it does, it's the iliofemoral. All right, moving on to the knee joint. And the knee joint does not have as much stability as the hip joint, but it is a very clinically relevant joint. I am sure somewhere along the lines you have either experienced yourself or know somebody that's experienced knee pain or some type of injury to the knee joint. It's a complex region right there. And it's actually a compilation of three different joints kind of in one joint cavity. And what these are you're going to have your two femorotibial articulations. So you're going to have the right femoral condyle articulating with the right tibial condyle. You'll have the and actually, this is my left hand. I know my rights and lefts. And then you'll have your right femoral condyle and your left tibial condyle articulating. And really, those are kind of two separate joints because you have two separate parts of the bones articulating. Also wrapped up within that joint capsule is the femoropatellar articulation. So that patellar surface of the femur, and you'll have the patella articulating here. So it's all kind of wrapped up together in this one really complex region. The joint capsule is going to be a bit more robust on the medial and lateral sides, less so anteriorly and posterior. And that makes sense if you think about the major motion that we have at the knee joint. That's going to be a hinge joint, flexion and extension. So the anterior and posterior portions of the capsule are not nearly as robust. In fact, anteriorly, it's almost completely replaced with a tendon. So again, this is a modified hinge joint. And what I mean here is that flexion and extension is by far the most dominant movement of the knee joint, but you are going to have a little bit of gliding and rotation that allows for the knee to kind of lock into place when standing. And that will allow for some relaxation of the muscle. So it's a bit more stability with a little bit of rotation. Now, we've talked about how flexion is typically a movement anteriorly, and that is true for most synovial joints. That is not true when we're talking about the knee joint. So flexion will occur with the leg moving in a more posterior position. So you can see that decrease in angle there, whereas you'll have an increase in angle in extension of the knee joint. Okay, so we don't have a particularly good fit between the bones. So the articulation is not particularly stable. So you need a lot of structures to help to protect and increase the stability of this knee joint. And really, there are muscles that are going to play a role, particularly in terms of the quadriceps femoris. But then there's a lot of ligaments that'll play a role as well. You're going to have what's referred to as extracapsular ligaments, so that are not a component of or not located within the capsule. The dominant one, again, is this patellar ligament or tendon. So remember, here's that quadriceps femoris tendon. So we think of our quads, that's in the anterior thigh, and it's going to have a really large tendon that will extend. So here's tendon. You can see the tendon all the way here, and then you get to the patella. All right, remember the patella forms within that quadriceps tendon. It's an example of a sesamoid bone. And then kind of from there on, from the patella down to this tibial tuberosity, then its name changes to the patellar ligament because essentially it is going from bone to bone, but it's really part of this larger complex of the quadriceps tendon. As mentioned previously, the anterior part of the capsule of the knee joint isn't particularly robust. In some places it's missing, but this tendon really kind of will serve to protect that anterior portion of the joint. So this is kind of, and if you're thinking anterior, I want you to be thinking patellar ligament or quadriceps femoris tendon. You can see that it sends these kind of offshoots. A retinaculum is going to be a widened tendon in this case. Okay, now we are going to get into collateral ligaments. Recall in our discussions when we were talking about ligaments and certain other hinge joints, if you have a collateral ligament, it's going to be located on either the medial or the lateral side of the joint, and that's exactly what we have here. So we have the fibular or lateral, sometimes you'll hear them either way, collateral ligament. This one is completely separated from the capsule, meaning that it's not a thickening of the capsule. In fact, you even have a muscle tendon that will move through this region here. So your FCL, you'll hear it sometimes FCL, or sometimes you'll hear it LCL. All right. And this, as its name would suggest, is going to be more laterally located. Then you're going to have the tibial or the medial collateral ligament. This is a capsular ligament, meaning it's really just a thickening of the capsule on the medial side, and it is inherently weaker than the fibular collateral ligament. This is much more rope-like on the fibular side, whereas it's flattened, not quite as strong as what we have on the fibular collateral ligament. Now, I'm going to talk about this a bit more in a moment, but I do want to mention it here, is that the tibial collateral ligament has an attachment to the medial meniscus. All right, so they literally will send fibers and they will kind of be connected in certain portions, and that is clinically relevant, and we'll talk about that a bit more in a moment. Now let's talk about intracapsular structures. So these are structures that are located within the joint. Two of the more dominant ones, and you've likely heard of a meniscus before, are the menisci. Menisci is plural. You'll have a medial meniscus, which again, we talked about is going to have an attachment to the tibial collateral ligament. So think the tibial collateral ligament would be kind of located right here, and the fibers in this general region would be attached. between these two structures. It's generally less mobile than this lateral meniscus, which tends to be a little bit smaller and a bit more circular. And these basically are going to sit right on top. So you'll have articular cartilage that's literally on top of the tibial condyles. And then on top of that, you'll have the menisci, that fibrocartilage. So kind of allowing for a slightly better fit with those femoral condyles. Also located within the joint cavity region is going to be these intracapsular structures, aka we're going to have these cruciate ligaments, and these two ligaments cross, thus the name. We're looking at a posterior view in this particular image. So the anterior cruciate ligament will be the more anteriorly located structure. So you can see this is an anterior view. So you see the ACL better. The PCL is a little bit more difficult to see. It's behind. Whereas if we're looking at a posterior view, the PCL is the dominant structure, and then you can see a bit of the ACL. This is important here. The ACL is going to be the weaker of the two cruciate ligaments. If you've heard of somebody having some form of injury to the knee joint, ACL pops up quite a bit. It's just an inherently weaker structure, therefore it is going to be damaged more often. The cruciate ligaments are going to allow for, or to disallow basically, displacement of the tibia on the femur. So in this particular case, or vice versa. So the ACL will prevent anterior displacement of the tibia on the femur. So it won't allow the tibia to move too far anteriorly. It will check that. Also, it will prevent posterior displacement of the femur on the tibia. So kind of that vice versa thing. So that is, when you're thinking of anterior displacement, think of tibia on the femur. Again, like you wouldn't be able to, that tibia wouldn't be able to move too far anteriorly compared to where the femur is. The posterior cruciate ligament, or the PCL, is the stronger of the two. It's going to prevent posterior displacement of the tibia on the femur, so not allowing the tibia to move too far posteriorly in comparison to the femur. This ligament, again, is strong. It's very important in terms of stabilizing the femur when walking downhill. So this is really playing a big role in terms of that stabilization of the knee joint. And it does a good job. It's a pretty powerful, strong ligament. Now, again, we've all heard of the knee joint, and we've all probably heard of it because of injuries. And so this joint just has more injuries than others. If you think there's a lot of weight bearing going on in this region, there's a lot of, if you have blows or to the side of the knee, this can cause injuries. And two of the structures that are very commonly damaged together are the tibial collateral ligament or the medial collateral ligament, same thing. Let's hear it either way. And the medial meniscus. Remember, those two structures are actually attached to one another. You can kind of visualize that pretty well right here. So often, if you have some type of injury to the medial meniscus, it will also affect the tibial collateral ligament. Now, we said the ACL is just one of the more inherently weak ligaments. So you can have what's referred to as an unhappy triad, where you will have injury to these three structures: ACL, TCL/MCL, and the medial meniscus. And this most commonly occurs with a blow to the lateral side of the extended knee. And that direction of the force, your fibular collateral ligament stays pretty intact because, you know, it's a stronger ligament, but that direction will just kind of blow through and start causing injuries or tearing to the more medial structures here. Also, excessive twisting of the knee can cause this to occur as well. So if you've ever heard of the unhappy triad or terrible triad, or if you hear it in the future, you'll remember that it has to do with these three structures. Can any of these be damaged individually? Absolutely. You can have just an ACL tear, or just a TCL tear, or just a medial meniscus, or even just a fibular collateral ligament tear, you know, PCL. They can all be damaged individually, but oftentimes when you see a more serious knee injury, you can kind of guess as to which of the ligaments or menisci are going to be damaged. All right, excellent. So that's the hip joint and the knee joint in a nutshell. we talked about some functionally important areas as well as clinically. And so do make sure that you go back to the learning objectives and make sure you can answer those questions. All right, so let's talk a little bit about a review of a particular area. So we talked about that the anterior portion of the articular capsule of the knee, I should put that in here, is incomplete. All right, so for most individuals, the capsule just isn't complete anteriorly. Which ligament functions as the majority protection of this anterior knee? So what is playing such an important part? And really the key word here is anterior knee. Is it the anterior cruciate ligament, fibular or lateral collateral ligament, patellar ligament, posterior cruciate ligament, or your TCL/MCL? So think about this one's a little trickier. And when you're ready, let's talk about how C, patellar ligament, is the correct answer. And really, I should have put in here quadriceps femoris tendon, because really these are just kind of the same complex. Now, what is the difference between the quadriceps femoris tendon and the patellar ligament? Well, the tendon is going to extend from the muscle bellies of the quadriceps femoris. It's going to go kind of over the knee joint, but forming within that quadriceps femoris tendon is the patella. And from the patella to the tibial tuberosity, that portion is going to be called the patellar ligament because it is going from bone to bone. And as we know, this is very anteriorly located. It's more superficial, it's extracapsular, so it's going to kind of be protecting that anterior portion. We do have a structure here that has anterior in its name. It is going to play a role in terms of preventing anterior displacement of the tibia on the femur, but it is not so complete that it's going to protect that whole anterior region. So this is not what we were going for here. The fibular and the tibial collateral ligaments are going to play an important role in terms of protection of the medial and lateral sides of the joint, but not so much in terms of the anterior. And the posterior cruciate ligament, very important in terms of preventing posterior displacement of the tibia on the femur. Also, if you think about walking downhill or walking downstairs, the posterior cruciate ligament's really playing a role in terms of that stability, but not so much in terms of the anterior portion. All right, excellent. So there was quite a bit to go through in terms of these joints. We will finish our discussion of the joints in the next video when we talk about the talocrural, aka the ankle joint. So I'll see you there. Thanks.